Good afternoon, everyone. Thank you for joining us here today.
It's 1 o'clock.
Good morning. Good afternoon, wherever you're at. Okay, good afternoon, good morning. Thank you for joining us. We're gonna go ahead and get started. And thank you for coming to our webinar on assessing equity in crisis response organizations and systems, tools, challenges, and strategies. We're excited for you all to be here. Before we get started, I would like to note that the views expressed in written conference materials or publications and by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does the mention of trade names, commercial practices, or organizations imply endorsements by the U.S. government. I'd like to introduce myself to you all. My name is Cindy Rivera, and I have the privilege of serving on the SAMHSA 988 Crisis Response Training, Crisis Systems Response Training and Technical Assistance Center. And you can see that our Assistance Center provides technical support to states, territories, and tribal organizations across the 988 Suicide Crisis Lifeline and Continuum of Care. Today's event is for training and education. It's a training and educational opportunity related to the design and operations of the crisis systems. If you need to chat with a crisis counselor, please call or text 988. And for additional training and technical assistance support or feedback, please contact the Crisis Systems Response TTAC at the email on your screen. Okay, now let's walk through our agenda for today. We are starting our time together with some introductions, and then we'll pass our mic along to our wonderful speakers. After the speakers, we will have a question and answer session that you can, you submitted questions via registration, or you can use the Q&A function within Zoom. After the Q&A, we will be having two of the groups that participated in the Embedding Equity Learning Collaborative to give a brief synopsis of what they learned during the collaborative. And then we will end our time together with office hours, where individuals can ask questions from the TTAC or request further assistance. So I'd like to take a moment to ensure that everyone in the audience is ready and comfortable with today's technical aspects of the webinar. As you can see, we have ASL interpreters joining us for today, and closed captioning is enabled as well. If you need tech support, please reach out by using the Q&A function and we will address it for you. Lastly, if you have questions for presenters during the presentation, please enter them into the Q&A area and we will address them as time allows after the presentations or during office hours. I also want to note that this program is approved by the National Association of Social Workers for one continuing education contact hour. We will share a QR code at the end of the speaker presentations where you can submit your evaluation feedback and request a certificate of completion. Good news for social workers. Okay. And our learning objectives for today. By the end of the presentation, attendees will have insight into the significance of conducting equity assessments to identify opportunities, gaps, and challenges within organizations operating crisis response systems. We'll leave with some familiarity of existing tools and methodologies for measuring equity and knowledge of how to apply them effectively within your organization. And we are going to understand the U.S. Department of Health and Human Services guidelines on conducting intensive equity assessments of existing programs, policies, and processes, as well as best practices and comprehensive approaches for equity assessments. And now I have the pleasure of introducing our partners from the SAMHSA 988 and Behavioral Health Crisis Coordinating Office, Laura House and Jill Mays. And at this point, I'm going to hand things over for them for a brief welcome. Oh, Laura, you're on mute.
Thanks. Good afternoon, everyone. We are so excited that you've joined us this afternoon, and we're just thrilled to have your participation. This webinar series is the product of a year of planning done by our office, the 988 Behavioral Health Crisis Response Coordinating Office at SAMHSA. And before we move forward, I want to thank our esteemed leader of SAMHSA, Assistant Secretary Dr. Miriam Delphin-Rittman, and her executive team for their support of this initiative and the 988 office overall. Speaking of the 988 office, this webinar would not have been possible without the guidance and unwavering support of our director, Monica Johnson, our deputy director, John Palmieri, and our division directors, Jill Mays and James Wright, and senior advisor, Richard McKeon, as well as each member of the 988 team. This webinar series is just one of many more opportunities to engage with the 988 team and Crisis Response Training and Technical Assistance Center. More information on how to access these opportunities will be provided by Cindy and the team later in the session. Now let's get to the reason we're all here today. Today I'm joined by some great subject matter experts in the field. And I want to take a moment to introduce them to you right now, and then let them share their expertise with you in our session today. First, I'd like to present to you Madhuri Jha. She is a nationally recognized clinical social worker and public health executive, advisor, and clinician. She has experience providing thought leadership, training, and education, consultation, and direct clinical practice to programs focused on health equity, behavioral health, systems strengthening, trauma and resiliency, mental health epidemiology, and community capacity building. She currently serves as the Vice President of Science, Equity, and Integration at ETR. She is also a practicing psychotherapist, and she sits on multiple legislative task forces to advance effective mental health policy. She's a professor of mental health policy at New York University. And prior to joining ETR, she was the director of the Kennedy Satcher Center for Mental Health Equity at the Morehouse School of Medicine. We're so excited to have her with us today. Next slide, please. And we also have joining us Dr. Diana Roberto. She is a 2024 National Poverty Fellow in Residence at the Office for the Assistant Secretary for Planning and Evaluation at HHS. She joins the HHS Equity Technical Assistance Center team and other work on engaging experts with lived experience in federal policy and research partnerships. Dr. Roberto conducts critical community engaged research about the experiences and agency of Black low-income populations in urban policy processes. Her research interests include racial politics, citizen participation, urban development, and arts and cultural policy. She recently earned her PhD in urban affairs and public policy from the University of Delaware. Next slide. Also joining us is Dr. Kimberly Aguilard. She is a health equity researcher at Mathematica. As a blind qualitative researcher, she is committed to engaging and empowering diverse communities, multiplying marginalized groups as equal partners to identify pressing needs and harness their collective expertise to formulate contextualized policy solutions. With expertise in equity, intersectionality, and social drivers of health, she has contributed to projects focusing on health equity, trauma-informed care, maternal health, and mental health. She played a key role in leading the equity assessment component of the Equity Technical Assistance and Training Center at HHS. She has developed training, tools, resources to enhance capacity for conducting effective assessments of equity and disparate impacts and the potential outcomes of actions to improve equity. So with all of that, we have some fantastic experts here to share with you. And with that, I'm going to pass things over to Maduri to get us started.
Good afternoon, everybody. My name is Madhuri Jha, use she, her pronouns. Thank you for the introduction by everybody who's hosting this webinar. I'm going to talk a bit about what it means to think about data equity and crisis response and provide some context to frame the remainder of our conversation where we'll learn in real time from partners who are implementing these strategies. Next slide. A little bit about the organization that I work for. ETR stands for Education, Training, and Research. It's a 40-year-old nonprofit organization focused on identifying science-based solutions to achieve positive health outcomes for children, communities, and their caregivers. And through our work, we improve the health and well-being of youth and communities by championing science, which means we try and identify evidence-based solutions to all of the things that we do. Next slide. By the end of our session today, my hope is that all of you can understand how inequities manifest in behavioral health, understand the impact data has on advancing equity and crisis response, and illustrate some indicators that you could consider tracking that could address these inequities wherever you're located in the country. Next slide. Some of the things that we do at ETR from an equity lens and using data to inform these things include applied research, evaluation, training, technical assistance, and capacity building, program development. We have a series of health promotion products that we administer across the country, evidence-based program dissemination, and lastly, of course, policy and advocacy work to use our data to tell our story to people who need to impact change. Next slide. And we do this at ETR through a tool that we established called the Health Equity Framework. It's an adaptive tool aimed at trying to help organizations identify spheres of influence that their work may be having across their practices. Next slide. The premise of the tool, which is one of the 7 HHS vetted adaptive organizational tools you can use, so we'll share the resource at the end, is that health and other wellness outcomes are influenced by complex interactions between people in their environment. So this is not a novel concept, that there are multiple spheres of influence that impact the way we think about outcomes, especially when it comes to health and the health and mental health outcomes intersecting with each other. These include physiological pathways, so that would be what I am born with, or what my family genealogy tells me is going to be an indicator of my health. Individual factors, so that could be my identity, the way that I present myself to the world, the way I see myself as expression to others. Relationships and networks, that would include my parents, my caregivers, my family, my friends, my teachers, my religious leaders, my community leaders, my life. And the last is the systems of power. And we're going to get into a little bit of detail of how this shows up for certain communities and behavioral health crisis response. That would be legislative policies, historical evidence, systems in place that have either helped or harmed certain populations from being able to advance positive health and mental health outcomes. Next slide. And it's based on 3 foundational principles that we use to operate all of our spheres of practice in. So that is that equity is at the core of health outcomes. There are these multiple interacting spheres of influence, and it acknowledges a historical life course perspective, so that everything, as we know here in the mental health space, is informed from the day we enter this planet to the day that we leave it. And all of them accumulate to influence the way that we can experience the world. Next slide. How we call it the HAF at ETR. We used it actually recently to redefine our vision and purpose. It is a unified framework across our products and services and administrative functions. It is a method to identify gaps in our work across content areas to make sure we're doing what we need to do to achieve health equity. It is used as a tool for staff reflection on what equity means personally and professionally. And lastly, it is also used as a tool to measure our impact through the spheres of influence. And again, that there's a way that you can utilize the HAF, which I won't cover in detail here, but we'll share that resource with you at the end. Next slide. So one of the things that I always say is that if there's no data, there is no problem. What does that mean? Is that there are existing data collection measures currently create barriers to understanding the intersection of equity and behavioral health. There are many communities in our country that have been historically harmed by data and research, and trust needs to be gained and acknowledged. Some of the most notorious accounts of this are the Tuskegee experiments in the South. Although those were syphilis oriented, there are others related to diagnosis of folks in the mental health community that have been harmful. For us to achieve 988 success, 988 must account for the collection and disaggregation of robust data and evaluation standards. And thoughtful collection and disaggregation leads to the development of tangible solutions that achieve equity. We have to reinvent the way that we collect data, and we have to think about it differently and innovate so that we can use what exists and also identify new strategies to reflect the communities that we serve. Next slide. So policy and practice considerations to embed equity into crisis response. I led the formation of a report at Morehouse School of Medicine called Embedding Equity into 988. And so these recommendations are actually inspired by those recommendations that I tailored for this conversation in particular. One of the considerations to always keep in mind is to uplift historically invisible identities on all facets of your implementation. So obviously that includes your staff makeup, marketing strategies, advisory councils, strategic partnerships, and of course, for the purpose of this conversation, data collection. Other considerations to consider, and I'll get into how we can think about this from data, is transparent communication with local law enforcement is key. We know that people are still calling 911, so that may be a way to consider looking at what's happening in your community. Wherever possible, employ licensed professionals and peer specialists, and also consider medical interpreters in areas where English is not the primary language and you may not have staff as well who can provide that service in the language that they speak. Again, there are ways and strategies we can capture who has those needs and sort of how we can represent them on our systems. We want to leverage the use of local clinics, community centers, and schools to partner with you along the crisis care continuum. This is also important when it comes to data collection. Participation is key across all facets of data collection, including the design of certain questions that you might want to get the answers to. I like to stress that we have to increase mixed methods to capture community experiences of crisis. I repeat, if there's no data, there's no problem. Mixed methods would mean that we're not only collecting quantitative data, we're also using strategies to get qualitative data, interviews, focus groups, opportunities to hear the words that people use directly. Again, this accounts for and complements the fact that many data instruments are pretty limiting to understand context clues that our systems really need to know in order to be the most effective. And lastly, implement comprehensive trainings that expand cultural responsiveness and humility. There are ways you can measure sort of where your organization stands and what the needs are based on where you serve and sort of how you can best meet the needs of your community. Next slide. So what data tells us, and this is that there are certain groups that are historically invisible in our mental health system. A lot of the lit that I have tended to scan over the years, I will just say this is broadly in our public health system overall. It's not surprising that it includes people who identify as LGBTQIA+, Black, Indigenous, and people of color, people living in very rural communities in the United States, immigrants, refugees, and non-English speaking people, people living with disabilities, older adults, people experiencing homelessness or housing instability, formerly incarcerated or justice-involved populations, survivors of trauma, which also includes veterans, and neurodiverse people. And the overarching part of this too is the experiences of young people under the age of 18 or 21 who are often not captured in most public data sets. Next slide. And we also know, it's probably a familiar image to most folks, that those outcomes for those populations become more dire when they start to overlap with each other and become intersectional. That all of these identities that we carry are related. And so if we have more than one that has been historically disenfranchised by our systems, our policies, our healthcare system, our outcomes may be harder, and thus we may present with more inequities in our communities. Next slide. So indicators. Indicators would be the types of measures that you would want to use to consider capturing in your system or organizational practice to understand the best impact your crisis response system can make with historically invisible groups. For the interest of time, I highlighted 4 that I think are strategies that all organizations can use. One is to take a look at your population demographics based on your zip code. That's including your race, ethnicity, language, or socioeconomic status. Most of this lives in county census bureaus, and it's publicly available. The other is to partner perhaps with the university institution in your area to conduct community needs assessments to understand how mental health is being accessed or perceived by the community you're served, especially in communities where there's still an existing stigma to access mental health services. Scanning publicly available data on issues like emergency room visits, homelessness, and rates of arrest. You can employ strategies to actually work with Medicaid and Medicare to get some certain things like how many emergency room visits have happened that have been psych-related. There tends to be data that is relevant to homelessness or folks who are attached to a shelter system. Also what overall rates of arrest are, although I will say homelessness and arrest rates tend to be underreported, but they tell you something about where you live. And lastly, using community-based participatory research or qualitative research methods to gain knowledge of trusted community supports for historically marginalized groups. This means that you're involving the community you serve in the research design, working with folks to ask the right questions using the language people understand, working with folks to help you recruit participants in your survey collection methods, and working with folks to help you understand the results. Be a part of the analysis and be a part of the recommendations that you may decide to employ based on the evidence that you collect. Next slide. And some rules of thumb for equitable data practices. So I always say to always think about whose story is missing. That goes back to that slide of what the populations of people that tend to historically always be ignored in healthcare. If somebody's story is not there, that doesn't mean that they're not being, they don't need the service in your area. They might just need more focused outreach. We want to engage people from communities across all points of data design and collection, as I said. As I also said, partner with trusted community supports to increase safety and reach. Can't stress this enough, in particular for LGBTQIA+ communities and BIPOC communities where there is mistrust in the healthcare system in general. And lastly, do no harm. We are all here as a measure to ensure that we keep our clients and the people we serve safe. That includes in our research practices as well. There are ethics that we need to follow as researchers and data collectors, just as we do as clinicians. And so we have to make sure that the research practices we employ don't perpetrate any harm. Next slide. So I'm going to give you some very quick examples of what I call data equity storytelling that can perhaps help you imagine how you could use equitable data practices at your agency. This is a slide I often use to kind of describe the behavioral health landscape in the United States, in particular for communities characterized by racial, ethnic diversity and poverty. We know about these two groups when we intersect those indicators together, that there's lower rates of long-term retention and behavioral health treatment, that there's existing stigma and cultural beliefs about psychiatry, that there have been historic misdiagnosis of Brown and Black children and adults, particularly I highlight ADHD and schizophrenia, that individuals with limited English speaking proficiency do have greater difficulty accessing care and staying in care. And one that's pretty alarming is that more than 150 million Americans currently live in what's called a federally designated mental health professional shortage area by HRSA, which means that they really don't have access to any kind of consistent or sustainable mental health care. This also includes prescribers, an MD or a nurse practitioner, who could be the overarching attending for their service. Next slide. I also want to highlight these statistics to think about data equity storytelling and what you might want to know about your own community. 911 response to crisis. It's important for us to know what's happening with police, especially as we try to make 988 a success. We know that last year, police across the US killed at least 109 people during mental health and welfare checks last year. We also know that this statistic of people with mental illness being more likely to be harmed by police is still 16 times more likely than the average civilian in the United States. And that tends to make up a wide range of 25 to 50% of victims. I might highlight that that percentage is likely higher. Next slide. This is another example of why data equity storytelling is relevant to equity. I highlighted suicide risk in Indigenous communities, and I used an overlay of the US Census and also what we know about suicide in American Indian, Alaska Native young people. So according to the US Census in 2010, we only had about 5.2 million people identify as American Indian, Alaska Native. In 2020, our US Census expanded a lot of the unique identifiers people could select. That number went up to 9.6 million people who identified as American Indian, Alaska Native. And we know now that suicide is the second leading cause of death among American Indian, Alaska Native youth aged 8 to 24. And American Indian, Alaska Native youth aged 10 to 24 have the highest rate of suicide of all demographic groups, right? So if we don't capture the burden of how much suicide is impacting communities and also capture how many people actually identify as American Indian, Alaska Native, you can imagine that there are a lot of folks who are going unaccounted for that we don't actually know. And when legislators, governors can't see the full breadth of what that is, it's very hard for us to make a justification to invest in equity in our crisis response systems. Next slide. The last example, I think this is the last example, is to understand perceptions of equity in the crisis response workforce. I referenced a report earlier. We conducted a survey at Morehouse School of Medicine prior to the launch of 988 that polled providers and leaders on the state of crisis response in the US. One of the questions that had a glaring answer was very simple. It was, is the current psychiatric emergency response system equitable? You can see here that we didn't have a single respondent out of hundreds that said yes, right? So that's really compelling when you think about how we make the case for equity in 988. Next slide. Sorry, last example here is another example of a report we did. We wanted to capture sort of how many dollars or lives could we save, a term that is very controversial, but often really needed for folks like legislators or policymakers or people who need to really think about how they want to invest in crisis response. If we made access to mental and behavioral health services more equitable across race and ethnicity. Next slide. And what we found out using publicly available data sets, I believe it was 5 across the US, was that we could save about 116,000 lives. And we could also save about $278 billion if we focused on BIPOC communities getting more access to behavioral health care. Next slide. So effective data practices can help inform really important outcomes. This can influence local to regional to national. It can influence additional intentional investment in crisis response. It can help shape culturally centered crisis response. And it can also help us effectively address political and social determinants of crisis response. That, of course, includes things like insurance, certain policies that exist that increase or deprive people from access to care, and also understanding where crisis response fits on the overall behavioral health care continuum. Next slide. That's it. That's all I have for today. Thank you. We'll take questions at the end as well. And I believe the next slide also has a QR code where you can find the health equity framework online and learn how to use it for your organization. Thank you.
Thank you for that awesome presentation, Madhuri. Hi, my name is Diana Roberto, and I use she, her pronouns. I am presenting with Kimberly Aguilar on behalf of the HHS Equity Technical Assistance Center to introduce you all to our equity assessment tool and training. So the goals of this training are to describe the key steps for equity assessments and then share available resources. We understand that the content of this presentation is pretty dense, but we hope to go through it in a clear way to make it easy to follow along and easy to implement once the training is over. Next slide, please. Before we get into the equity assessment tools, we're going to discuss what we mean by equity. So what is equity? The consistent and systematic treatment of all individuals in a fair, just, and impartial manner, including individuals who belong to communities that often have been denied such treatment, such as Black, Latino, Indigenous, and Native American, Asian American, Native Hawaiian, and Pacific Islander persons, and other persons of color, members of religious minorities, women and girls, LGBTQI+ persons, persons with disabilities, persons who live in rural areas, persons who live in the United States territories, persons otherwise adversely affected by persistent poverty or inequality, and individuals who belong to multiple such communities. For these tools, we use the definition that is consistent with the President Executive Order 14091, which emphasizes fair treatment of all, including people who belong to communities that have been systemically denied such treatment. So now I'm going to kick it over to Kimberly Aguilar to introduce us to the equity assessment steps.
Great. Thank you, Deanna. I am Kimberly. I'm so excited to be with you today. I use she, her pronouns. So, equity assessments are systematic examinations of available data and expert views on how various groups, especially those facing inequity, are affected or could be affected by a policy or a program. So, these assessments help agencies understand how their programs and policies may perpetuate barriers to opportunities and how to improve policies and programs. They can also help assess how program and policy changes might affect equity. So, quick note, when we refer to experts in this context, that includes people with lived experience with programs and those in communities most often marginalized or harmed by systems, policies, and institutional practices. It can also include researchers and providers and other key constituents. So this slide shows 6 key assessment steps that many equity assessment tools include. So we've got identify the program and policy and population, consider context and drivers of disparity, collect expert input, including from affected community members, identify information sources and gaps, analyze policy or program effects, potential or current, on people and communities, and then plan for action and accountability. So we'll give an overview of the goals for these steps and some examples. Some of the prompts that you see in the overview for each step might not be relevant for a given assessment, so teams can just prioritize the most relevant prompts, especially if they don't have time or capacity to address every single one. And likewise, we don't have time here today to give examples for every single prompt, so we're just going to focus on 1 or 2 per step. Next slide, please. So we're going to start with step 1. The goal for step 1 is to describe the program and population fully and with specificity. So to do this, start by thinking through what populations are participating in a program or might be affected by a proposed policy. And importantly, who is left out or not fully benefiting from it. You should decide on a comparison population or a reference point for known disparities, and be sure to consider intersectionality, which are those ways that population groups' characteristics overlap, exposing them to relatively greater inequities. Starting out your equity assessment like this by including all populations that might be affected by a policy really helps assessment teams avoid perpetuating disparities among populations that might have been overlooked in the past. And it helps teams consider what all populations really need to thrive. Next slide. So if your assessment focuses on populations with disparate outcomes, including a point of comparison or reference, can help clarify the magnitude of the disparity. So this slide shows an example of two different reference points. So infant mortality of children born to Black birthing persons is 13.6 for 1,000 live births. This is much higher than the group with the lowest infant mortality rate, 4.9 per 1,000 live births for Asian or Pacific Islander birthing persons. And it's also higher than the benchmark set by Healthy People 2030. That goal is 5 per 1,000 live births. So the best reference point really does depend on the context that you're working in. You may also want to choose more than one just to explore or describe disparities in different ways. The really important thing is to be clear about the reference point or points that you're using and why, and what the comparison suggests about how to prioritize improvements. It's also important to be intentional when you're choosing these reference points and not just automatically kind of default to the same demographic group every time. Next slide. All right, now we're moving on to step 2, consider the context and the drivers of disparities. The goal for this step is to explain disparities and inequities, consider institutional roles in producing or resolving them, and place focus on institutions instead of on groups of people. So, root causes of disparities may be intertwined with social and cultural histories of populations involved. And to explain or to better understand observed disparities, it's really important and helpful to ask about the legacies of racism or the cultural oppression that a particular population might be inheriting, and recognize the structural and social inequities that might be contributing to these disparities. So structural inequities refer to those governing processes and economic and social policies that distribute power and resources in unfair ways. So think like an inequitable distribution of emergency funds to certain communities. Since fairness is not always immediately obvious, determining that is part of the task for the equity assessment team. And then social inequities are differences in conditions in which people are born, grow, live, work, and age, like poverty, employment, or housing. So you might kind of know of these conditions as social determinants or social drivers of health, but they can also encompass other aspects of health beyond health, like economic outcomes that we also really care about. And then finally, it's helpful to consider context for the policy itself. So, for example, by asking whether institutional racism or other structural barriers have affected implementation and outcomes of previous programs and policies. Next slide, please. All right, step 3, collect expert input, including from affected community members. So the goal of collecting or analyzing expert input is really to inform the assessment and learn from the communities affected by policies and programs. We don't always know what we don't know, and engaging with people with lived experience from affected communities is key to understanding inequities and barriers. So for current programs and policies, look for opportunities to engage experts with lived experience with those programs, including those historically excluded from decision making and those people who might be eligible for programs but who are not participating. Then for proposed policies, you can start with what's kind of already known about expert views. You can do that either through previous expert input or through the literature. You can also kind of identify future ways to involve experts in shaping and carrying out and evaluating the policy. Next slide. So here is a real example of what expert engagement can look like and involve. In a 2021 report, the Raise Family Caregiving Advisory Council delivered 26 recommendations on how the federal government and others can better recognize, assist, include, support, and engage, or raise family caregivers. Council members, including people with lived experience, caring for family members, and then the council also sought public input from caregivers, community-based organizations, and other key constituents. So recommendations included the need to strengthen trainings for professionals, to maximize family caregiver engagement, and to increase access to meaningful and culturally relevant information, services, and supports for family caregivers. So to summarize, there was an existing advisory council set up, and the council helped the office collect additional public input. So an advisory council with people with lived experience is fantastic, but if your assessment team doesn't have something like this in place, don't worry. Teams can also use methods like doing interviews, focus groups, listening sessions, or consultations to inform the assessment. Next slide. Now I will turn to step 4. This is identifying information sources and gaps. So the goal here is to gather and describe information sources to support the assessment and document information gaps. So as part of this step, assessment teams can take stock of the available quantitative and qualitative data sources for the assessment and explore whether quantitative data can be disaggregated or broken down by relevant variables like race and ethnicity and income and geographic location. Another really key part of this step is documenting gaps or limitations in the information needed for the assessment. So if assessment teams are hitting walls and facing data or information gaps that really make it difficult to understand disparities and their drivers, they should absolutely note those and think about how to get new or better information in the future. So it might feel a bit uncomfortable or cringy to document holes or limitations in our data, but it's also necessary as a first step before advocating for authorities or investments in better data to improve programs and promote equity. Next slide. All right, so with that, we are already on step 5, which is analyze policy or program effects, potential or occurrence on people and communities. In the analysis in step 5, assessment teams really draw on all previous techniques, steps, and learning to describe equity-related outcomes. So for current programs and policies, assessments describe findings on inequities or disparities, including those contextual factors that might be driving them. Teams can also consider whether or how experts help to interpret data and findings. And then for those proposed policies, assessments discuss the positive equity impacts that could result from the proposal. They identify any potential adverse impacts too that might unfold without specific implementation strategies, and think about whether the proposal could affect drivers of disparities like social or structural inequities. Next slide. So we're honing in now on step 6, which is planning for action and accountability. This is a key step to ensure that the work that the analysis and the assessment team did for steps 1 through 5 is really used to make improvements that lead to better outcomes in the long run. Like that's what we're here to do, right? So this step is really important. So the goal is to use findings of the equity assessment to plan actions needed to realize positive outcomes. So this involves kind of formulating action steps with a few components, things like identifying implementation strategies or complementary policy strategies needed to realize expected outcomes, making a plan for dissemination or sharing the assessment, and planning for accountability, which may include program improvement, monitoring, and evaluation. So in general, articulating and really thinking through these initial plans for action steps is part of the equity assessment, even though the actually putting those plans into action happens after it's over. Without planning and conducting these steps, assessment teams might not achieve the expected positive change that you're hoping for, or learn whether actual outcomes are matching predicted ones. So first, implementation strategies, I'll break this down a little bit more. That means sort of describing needed actions or complementary strategies to realize those positive equity impacts that we are all hoping for. This is really important because we know realistically policies and program changes, they don't just sort of automatically magically result in positive outcomes, right? They require rules and guidance and operation and coordination and training and all sorts of other actions to support the change. This is another area where experts can really inform these plans by weighing in on aspects like plans to remove service barriers or plans for training field staff differently or improving consumer education materials, a whole lot of different ways. Next slide. Now we're going to talk for a second about accountability. We're using this as an umbrella term for program improvement activities, monitoring, and evaluation. So accountability helps ensure the equity assessment actually contributes to equity improvements and makes anticipated positive changes more likely because it helps teams know if implementation needs any adjustments to realize those positive outcomes. So we're all learning, and tracking impacts is a really essential part of that continuing learning process. There is a ton packed in here, so I'm going to break it down just a little bit more. So the goal for planning for improvement is to make actionable game plans to address those inequities that you've identified through your assessment. Plans for improvement should describe the processes and actions needed to achieve those outcomes. And this plan might encompass elements of monitoring and evaluation so that the team is checking progress. So this is the stage where the assessment team really gets to focus on solutions to resolve those observed inequities or their drivers. A good strategy is to quantify sort of short-term and long-term goals for improvement. That can really help you monitor and evaluate progress. The team next can list the steps needed to accomplish sort of each goal. And this is another great time to invite experts to weigh in with important perspectives on solutions and goals and action steps. And then finally, consider what resources you actually will need to carry out the improvement plan. So monitoring, as most of you probably know, means routine data collection to check whether trends are moving in the right direction. The actual monitoring activities might happen after the formal assessment is done, but it may be helpful to go ahead and decide on one or two measures as part of the assessment process. And then the evaluation is the analysis of outcomes in a defined period to learn whether changes had intended results. So even again, though the evaluation happens after the assessment, it can be really helpful to decide on outcome measures and maybe even assign some responsibilities for evaluation activities during the assessment. Next slide. So now I'll get into a few more quick details about choosing measures for monitoring and evaluation. So effective goals are quantifiable, measurable targets that support objective assessments of improvement and drive more specific actions. So start by considering how you would know if outcomes play out as expected. Like, what should change? Is this even measurable? Could we monitor progress towards the goal? So in the lower part of the slide, we've given some examples of goals that range from pretty general to more specific. So on the left is an example of a general goal: improve mental health status for LGBTQIA+ youth. This is a good goal, right? We can get behind this. What is missing is how or how much. It's not really clear from this goal how a team could tell that this is changing or what the data source would be, or whether it would be possible to even connect such a general goal to a given improvement. So the middle goal is more specific, and that's to reduce the percentage of LGBTQIA+ youth who report seriously considering suicide using an established survey. And then an even more specific goal is on the right, which is to reduce the percentage of LGBTQIA plus youth who report seriously considering suicide by 10 percentage points from baseline to year 3. So both of the more specific goals are clear and measurable and stronger than the general goal. The difference between them is that the second defines a target for the amount of change. Either might work, just depending on the context for the assessment and the program goals. A logic model is a great tool for setting up measurable goals and choosing monitoring and evaluation, short and intermediate and long-term outcomes. They also can kind of help clarify the timing of the outcomes, map out action strategies and steps, and help make sure that everybody is on the same page when you're having discussions with experts and partners. Okay, I know that was a crash course. Thanks for hanging there with me. I am now going to hand it back to Deanna to share some other resources to help you on your sort of equity assessment journey.
Thank you so much for walking us through all of the steps of the equity assessment, Kimberly. So I'm going to conclude with a walkthrough on some of our resources. Next slide, please. Thank you. We have 2 public equity assessment resources. We have a tip sheet and an in-depth guide. Both explain the 6 core steps that Kimberly walked through during this presentation on equity assessment. However, these are like the key differences. The tip sheet provides suggestions for how to complete each step and then relevant examples. And then the in-depth guide gives a detailed description of the steps and questions to consider through each of these processes. This next slide has a link, so I'm just going to pause for a second so that y'all have a chance to write it down if you're interested in the tools. And just to walk you through what we have, I also wanted to mention that we also have a number of other equity focused tools on engaging people with lived experience, research and analysis, and then we have more available on our website that might be of interest. So these are just some examples of some of the tools that we have available. So definitions of lived experience, qualities of equitable and inequitable engagements, identifying individuals with lived experience and recruiting individuals with lived experience. On the research and analysis front, we have a guide on centering equity and quantitative analysis, a guide on addressing intersectionality in analysis and measuring success in advancing equity. And then some of our other tools include a tip sheet on equitable communication and a tip sheet on engaging diverse external partners. So thank you so much. If you have any questions, please feel free to contact us, or if you have feedback at this email right here, which is the equityta@hhs.gov email. Thank you.